in determining first-line therapy in our patients with CLL, there are many things that are important to consider. So certainly the disease characteristics are important, right? So knowing their cytogenetics or FISH, what sort of chromosomal abnormalities that they have associated are very important. So if they have a 17p or p53, and their mutational status, so knowing if they are unmutated or versus mutated, that's very important to know, because again, for those subgroups, I think many of us would move away from chemoimmunotherapy or chemoimmunotherapy alone. If they're part of a clinical trial that has a novel agent plus some chemo, that's different, because they're getting a novel agent, but certainly we would move away. So those are important, but then you have to take into account patients' age, comorbidities. I mean, really comorbidities. I think age isn't becoming as relevant anymore as opposed to the era of chemoimmunotherapy, when we really did, the older, frailer folks, we would move away from chemoimmunotherapy or dose reduce and things like that when we didn't have all these novel agents. But now having these novel agents, I think that, age is, agnostic. Older patients can receive really good therapy now for CLL, which is fantastic. But comorbidities are still a problem, and that may help select what your decision making is for folks, if they have cardiac issues, if they are on anticoagulation or antiplatelet agents. And so you may, decide based on their comorbidities whether you're going to use a BTK inhibitor versus using a venetoclax-based regimen. If they have renal insufficiency, poor kidney function, so then if they're at higher risk for tumor lysis, are you going to choose a venetoclax-based regimen? And then, of course, patient preference, because clearly there are strategies that are evolving. The BTKIs as monotherapy has been continuous chronic therapy, and so that's one strategy and approach. And of course, now with the venetoclax-based combinations, looking at more time-limited durations of therapy, so something that's shorter, but obviously, may have more issues up front when it comes to monitoring for tumor lysis and myelosuppression, such as neutropenia. So, you're going to talk about those options with your patients, of course. So there's patient preference. There's logistic issues. So if the patients are able to come to the clinic more often, or if they need hospitalization, depending upon their comorbidities or tumor lysis risk factors, if you're gonna give a venetoclax-based regimen. And so all these need to be considered. I mean, I think paramount for consideration from my standpoint was always, disease characteristics, and then patient comorbidities, and then obviously talking that in addition to the patient's preferences and other issues surrounding that, what might be best treatment options. So you may choose to move away now that you have multiple options of therapy. You may then select things based on their comorbidities and decide to move away from one versus another, based on those options and patient preferences. So I think you have to consider all these factors now that we have multiple therapies for our CLL patients, which is fantastic. But you have to consider all these options, with your patient, and ultimately, a longer conversation, it has to be held now that there are these options and there are many factors to consider. So those are just some of the factors you got to consider in frontline therapy.